how does living with cardiovascular disease influence one's daily life? One, and if you can add to that as well, what strategies can individuals kind of adopt to manage on top of what we've already mentioned?
Yeah. I think to answer the first question, it's probably useful to split or break down cardiovascular disease.
Go on.
And I'd probably break it down into the risk factors. So hypertension, high blood pressure, is technically a cardiovascular disease. It is a CVD, but it doesn't give you problems, pain, or symptoms. It increases the risk of other problems later down the line, stroke and heart attacks. And I'd probably then split that is very different to living with. You won't know anything at all until it happens. And then after a heart attack or stroke, you're now in a completely different phase. And your risk is absolutely different. Your risk of future one is way higher than everybody else. Okay. And you have significant pain and disability to contend with. So I don't say heart attacks and strokes to people. I say pain for heart attacks and strokes is disability, because I think that's more understandable to everybody. Whereas heart attacks and strokes become something you see on a billboard or something a doctor says, or
on a TV show, yeah.
Yeah,
movies.
But pain and disability, everybody knows that. Everybody understands that. And I never thought I would be in CVD because I thought it was about cardiologies and survival and all-cause mortality. For me, it's quality of life that's important. I think most people, it's quality of life rather than quantity of life. I now see that it causes pain and disability, and people unfortunately don't die. You live.
Yeah.
Many patients tell me, I don't care if I die tomorrow. That's not the problem. The problem is that you will live and you will suffer, and it could have been avoided. And that last bit makes it hurt a bit more.
Yeah.
Wow, that's powerful.
Yeah.
So I like the way you've broken it down. So then how does one prevent, in terms of getting to the stage of stroke, when it comes to the other side you mentioned, which is the high blood pressure side, the hypertension, those elements?
Yeah, if we take it separately, so there's hypertension and there's cholesterol.
Right.
Everybody will have heard the general standard advice about being healthy.
You hear it all the time.
Yeah, maybe have some finger wagging at you in the process.
Yeah.
Don't drink alcohol, lose weight, move more. It's like, yeah, great. But it's a complex, and so everybody is starting at a different level, and what people need to do is dependent on them and the mix of factors in their life, which is why it's impossible to do this well in 10 minutes, by the way, because you need to know exactly what someone does in their life really quickly to then give decent, personalised advice.
And you sort of have to rely on them being honest as well.
That's on them. No, but that's on them. Everything they say is taken at face value, and so if you want the doctor to help you, then it's up to you to be honest. That is an absolute responsibility of each individual when they interact with their healthcare person, isn't it?
Pretty interesting you say that, because obviously we spoke previously in our pre-production about how my father has had a stroke twice recently. And the duty of care has now, moved on to the family members as well. So it's no longer a thing where my dad can actually express and say, okay, I've gone through this. To be honest, he won't even admit it. So it's now come to the point where we have to kind of break down the symptoms, the things that he's been going through. And we've been quite observant over his lifestyle, just because we know that whenever he's had a stroke, I remember when he had his last stroke, he went to the point of actually expressing and saying, I'm fine. Like he was struggling to speak, and as he was struggling to speak, he expressed that he's fine just because he didn't want any medical intervention. And just to that point, how do you cope with patients that don't want to admit that they are suffering? And is it common in certain ethnic minority groups?
Yeah, it's common across the board, and it's the hardest thing to deal with as a doctor, as an individual. Our whole role is to help, but we aren't people's parents. We're not the police. And it's really hard because sometimes our hands are tied behind our back and there is nothing. I can't exercise for you. I can't do any of that stuff. And as a doctor rather than a healthcare professional, which is way broader, there's care coordinators, there's a huge amount of people out there, dietitians, who can go into all the depth. So, but as a doctor in the consultation room, as much as I hate it, the role is kind of fixed and it's about certain things, and it's so hard. It's really, really hard, and that's the social element in the biopsychosocial model, isn't it?
Yeah.
So it does link, because I think about that, but I can't change necessarily that overnight. And I always listen to family members, and often people are brought by their family member. It's not too uncommon. They're dragged. And it's like, well, thank you very much for bringing this person here. They really needed it, and I'm really glad you're here.